Audio Jungle.
A butterfly-shaped distribution, typically bilateral and symmetric alveolar filling pattern is seen. So, in both lungs, there is more white appearance and butterfly-shaped distribution. Interstitial or mixed or diffusely nodular and focally dense patterns have been reported. If this appearance is seen on X-ray, then DD is ARDS and pneumocystis jirovecii, coronary pneumonia, and hypersensitive pneumonitis. Here in this X-ray, right lung apex, there is some more white appearance than the left lung. So this can be consolidation. Here on the right lung, lower lobe, more white appearance than the left lung. So it can be consolidation or blood or fluid. Lung field abnormalities. Interstitial disease. Nodular pattern. A nodular pattern consists of multiple round opacities generally ranging from 1 mm to 1 centimeter. Nodular opacities may be miliary nodule or pulmonary micronodule or pulmonary nodule or pulmonary mass. If it is less than 2 mm, we call pulmonary miliary nodule, and more than 30 mm is pulmonary mass. Next, circulation. Cardiothoracic ratio. Ratio between maximum diameter of heart to the maximum internal diameter of the chest. Normal is less than half. 2/3 of cardiac shadow lies on the left side of the chest. So if you see this cardiac shadow is less than half or half, we can. If it is more like this, then it is cardiac enlargement. Here this is aortic knuckle showing enlargement. So this is aortic aneurysm. This is Chilaiditi sign. Once again, to revise, the central is trachea. So for tracheal position, we should look for vertebral bodies and spinous process. Then this is aortic arch. Then here pulmonary trunk, and this is left main bronchus. So see the translucent area, and this is pulmonary bronchus. This is left main bronchus and this is pulmonary trunk. Then this is left ventricle and diaphragm here and inferior vena cava. This is right atrium. Oh, this is manubrium sternum. And this is here superior vena cava. This is gastric bubble. So what is the difference between AP view and PA view? So in AP view, clavicle is seen above the apex of the lung field and scapula inner borders seen over lung fields. Anterior ribs better visible and apparent cardiomegaly will be there. In PA view, the patient holds film like this, so the scapula inner border seen away from the lung fields and clavicles seen over the lung fields. And ribs, posterior ribs are better visible. There will be no apparent cardiomegaly. This is AP view showing apparent cardiomegaly. This is PA view, where scapular borders are away. This is AP view, where scapular borders are in the lung field. This is normal appearance. So this appearance is called boot-shaped heart, where there is concentric LVH, left ventricular hypertrophy. Sorry, if the apex is enlarged towards upside, it is right ventricular hypertrophy, the appearance is boot-shaped heart. But cardiac enlargement of left ventricle, it is towards the downside. Next, diaphragm. Normal cardiophrenic angle is conical and sharp. Normal cardiophrenic angle is conical and sharp. Here there is blunting of costophrenic angle due to pleural effusion or blood collection or anything. Next, bones. This is bones fracture that is showing. Here bone fracture. So how we count ribs? So this is first rib. This is PA view. So from back side, if you see, this is front side of the rib. This is back side of the rib. First, then here second, then here third. Third. Next, 4. Like that, we have to count the ribs. Normal inspiratory film shows 9 to 10, 8 to 9 ribs. So here X-ray is showing the fractures, multiple rib fractures. There is bone discontinuity is seen. Here clavicular fracture, here also there is scapular fracture. Here also there is bone fractures. This is foreign body in X-ray. This is chest radiograph showing nasogastric feeding tube in lower lobe of right lung with infiltration.